Hello everyone, and welcome to the scholarly project of identifying childhood trauma and improving trauma-informed care in behavioral health. Childhood trauma has been linked to significant mental health issues for adults. Healthcare staff on the Behavioral Health Unit, or BHU, at the identified hospital have already received education on providing trauma-informed care. However, patients with childhood trauma are not being identified. Trauma-informed care cannot be clinically delivered if trauma is not recognized and communicated. Interest and expertise. This author has been practicing as a registered nurse for 17 years, at the bedside and in various leadership positions throughout the hospital and mental health environments. Holding a master's degree in nursing, or MSN, and working towards a DNP, or a doctorate of nursing practice, also provided a significant amount of education and knowledge to be applied throughout the course of this project. As a DNP, this researcher is specialized as a psychiatric mental health nurse practitioner, or PMHNP. Therefore, education received is focused on mental health. Nearly 2/3 of all children experience trauma by 16 years of age. The high number of people facing traumatic experiences throughout their lives makes it imperative that trauma is identified and addressed by healthcare providers. As a soon-to-be PMHNP, this researcher had the desire to address this deficiency in the care provided at the designated hospital. The purpose of the scholarly project was to improve the delivery of trauma-informed care that the nurses had already been trained to provide. Thus, the aim was to improve the ability of healthcare providers to provide trauma-informed care. A secondary aim of this project was to improve identification of childhood trauma, utilizing the Childhood Trauma Questionnaire. Another secondary aim was to improve communication amongst healthcare workers when someone has a history of trauma. This project was a practice improvement project, directly addressing the identification of patient trauma history and the communication of it amongst healthcare workers, allowing them to provide effective and sensitive care. Screening for trauma, including childhood trauma, is a component of trauma-informed care. Trauma-informed care is a way of approaching the care provided to people that allows for transparency and sensitivity to what each individual person has been through in their lives and how those experiences may be connected to their current situation. The implementation of this project, specifically utilizing the Childhood Trauma Questionnaire, enabled the nursing staff, advanced practice nurses, and physicians to provide trauma-informed care more effectively. Being informed of a trauma history will allow all these specialties, or did allow all these specialties, to be sensitive to the individual needs of each patient. The scholarly project also directly affected communication amongst staff, allowing for improved quality of care. As with the intake assessments that nurses conduct, diagnosis on patients with mental health and behavioral health disorders can pose a challenge due to the complexities and externalities associated with such disorders. The Childhood Trauma Screening Tool provided additional contextual data points for diagnostic consideration and the development of a treatment plan. As evidenced previously, childhood trauma manifestations can be varied in typology and magnitude, and may be an underlying or contributing cause to a disorder. Providers can provide better diagnosis and treatment plans if they are addressing a root cause. As with nurses, first impressions matter in establishing patient rapport. By understanding not only the current psychological state of the patient, but also some factors that have led to that state, practitioners can employ methods of interaction with the patient that are best suited for each patient's needs. The patient will likely see the provider as more empathetic and trustworthy. This can lead to better rapport with the patient. Ultimately, by improving the understanding of the patient and adjusting approaches accordingly, trust can be improved. The theory chosen that best fit this project is Kathy Caruth's theory of trauma. Carruth discusses that experiences of trauma stay with people forever. One needs to share these experiences with others to learn how to heal. Her key takeaways are that trauma changes you, trauma experiences are hard to express, and trauma stays with you throughout your life. If those key points are correct, then trauma should be recognized in people, and they should be treated by professionals accordingly. Their interactions should be individualized based on the patient's personal experiences. In the traditional trauma model by Kathy, trauma is viewed as an event that fragments consciousness and prevents direct linguistic representation. The model draws attention to the severity of suffering by suggesting that traumatic experiences irrevocably damages the psyche. To address the research question, one must first understand three things. First is the profound effect that childhood trauma has on a person throughout their life. Second, the importance and effectiveness of providing trauma-informed care. And third, the data supporting the use of the Childhood Trauma Questionnaire. Therefore, the research question at hand is, in adult hospital patients admitted to the behavioral health unit, can utilization of the Childhood Trauma Questionnaire on admission improve implementation of trauma-informed care by the end of 8 weeks? A search was performed based on the research question just stated. The databases searched are included here, as are the Boolean phrases and the search parameters, in the hopes of spending more time on the review of research as well as the results of the project. I'm not going to read this part aloud. Supporting evidence. Multiple studies showed that childhood trauma is related to many adult mental health issues. The takeaways from the research is that childhood trauma is associated with suicidal ideation. It was found to be a significant precursor to suicide risk, and there was a greater increase in suicidal ideation with those that experienced childhood trauma. However, the most compelling results were that there was found to be a 5-fold increase in suicidal ideation and a 3-fold increase in suicide attempts in those that had a history of childhood trauma. Moving on to identifying trauma history. Identifying trauma history is the first step in trauma-informed care. As stated previously, trauma-informed care is a way of approaching the care provided to people that allows for transparency and sensitivity to what each individual person has been through in their lives, and how those experiences may be connected to their current situation. There are multiple studies that supported the need to identify trauma history, including that it improves patient satisfaction with their care, it increases planned discharges, and it helps with acceptance and emotional regulation. And it was found to improve the lives of not only the patients, but also the providers. Supporting evidence. Finally, the research for the Childhood Trauma Questionnaire. This questionnaire is self-administered by the patient and was found to be reliable, consistent, and of high quality. It was also found to identify previous trauma regardless of the time frame. Literature critique. Let's discuss the critique of the literature, starting with strengths. All but 5 articles specifically stated that they obtained Institutional Review Board or IRB approval prior to starting their studies, and that they obtained informed consent from the participants. The setting of the articles varied from study to study, which is seen as a strength. With the variation in setting, it shows the overall effectiveness of the tool and trauma-informed care. Another strength is that almost all of the studies, the sample was randomly selected. This is a strength because it helps to make the findings more credible. Moving on to gaps. Most of the studies were rather small, so the sample size was a gap or a weakness. Specific populations were also used, such as only university students or only those diagnosed with PTSD. And the majority of the studies only included females. So as for limitations, all were retrospective with the childhood trauma questionnaire, and again, that smaller sample size. So we need more studies with males and more studies on adolescents and children. Design. So these are the steps of the current project. Step 1 is the pre-project data collection. Step 2 was educating the nurses about the project and the process that was followed. Step 3 is when they began providing the childhood trauma questionnaire and placed the results in the communication log. Step 4, we assessed compliance with the project and re-educated staff as needed. And then step 5 was post-project data collection. Patient inclusion criteria was that they must have been 18 years of age or older. They must have been admitted to the behavioral health unit between January of 2024 and May of 2024. They had to be English speaking. They had to be alert and oriented. Exclusion criteria was everyone not meeting that inclusion criteria that you can see here. All races and genders were included in this project. Nurse inclusion criteria. They had to be employed as a nurse on the behavioral health unit, and they had to be employed from January 2024 and May of 2024. So in other words, if they were floated to the behavioral health unit or they were employed by an agency working at the hospital, they were not included in this study. All races and genders were also included for the nurses. Protected health information. So there was no protected health information needed for the purpose of this study. While the childhood trauma questionnaire was used, the responses are not what was being studied. Chart review was used to gather information, but again, no PHI was necessary for this study. All information was yes or no. This research project was conducted as a quality improvement project. Qualitative data was obtained prior to, quantitative data was obtained prior to the project period, as well as post-implementation of the project. Instruments and measures. So measure 1 was how many times was trauma asked about prior to the intervention compared to how many times the childhood trauma questionnaire was administered. Measure 2, how many times that trauma was identified and communicated to the staff prior to the intervention compared to how many times it was communicated after the intervention. Statistical test was the Z-test for the difference of two proportions, and of course, the childhood trauma questionnaire. There were many methods utilized to ensure the quality and adequacy of the data collected. All of the BHU, or Behavioral Health Unit staff, including the director, manager, were trained on the project, and I apologize. All of the Behavioral Health Unit nurses, including the manager and director, were trained on the project, data collection, and the importance of accurate and complete data. Upon completion of the project, the researcher was the sole data collector. Charts were audited twice by the researcher to ensure inclusion and exclusion criteria were met. The childhood trauma questionnaire was then compared to the communication logs twice. Finally, all data that was recorded was reviewed and checked twice. The purpose of checking everything twice was to ensure that the data collection was accurate and nothing was missing. This project did go through the Investigational Review Boards, or IRB, at both the school and the hospital. Both boards ruled that the project was exempt from needing official IRB approval, as it was considered a quality improvement.